Today we're talking about the SI joint and the differential diagnosis thereof. This is a joint that can be affected by fairly serious conditions, including infections, systemic and reactive arthritis and so on. Most of the problem though lies with biomechanical dysfunctions, at least that we see in our clinics. It's worth noting though that it's estimated that only about 13 to 15% of back pain is caused by the SI joint. Now, I'd argue that's not true. More accurately, I would say that 13 to 15% of all back pain arises from the SI joint. I think the SI joint plays an etiological part in the process of back pain. Every now and then, though, it will be painful. So this is what we're talking about today. These are the differentials we're interested in. Sacroiliitis, this is inflammation of the sacroiliac joint, and depending on the context of the conversation, a lot of people will only talk about the systemic problems there, whereas in fact I'm going to use the term arthritis, meaning the joint is inflamed, so that's going to include systemic arthropathies and so on. So I'm not confining it to this, but you may want to define terms when you're talking to a rheumatologist, for example. Anyway, the systemic arthritis is ankylosing spondylitis is obviously the most common one, but the one that is most unexpected is reactive arthritis. And the problem is you have a tendency to think of ankylosing spondylitis only occurring in men and boys, whereas in fact it occurs almost equally in both genders. But with women, the male form of ankylosing spondylitis, where it does affect the SI joints, is retermed reactive arthritis because it's part of bigger disease processes, Crohn's disease, Reiter's disease, and so on. But they look exactly the same, basically. Reactive arthritis is almost always ankylosing spondylitis in every detail of its features, except that it's occurring with more systemic conditions. So these are going to show up as severe sacroiliitises. Infectious arthritis, this can be really bad. I mean, this is a big joint, so it can get very infected and very, very painful. And this is one of the causes of the sign of the buttock. But it can also be very low-grade chronic infection. So when you're looking for things like temperature increases, general malaise, swelling and so forth, that will probably be present in an acute inflammatory process, but maybe not so much with a chronic disease process. So you're going to have an insidious arthritis present, which is always something to be careful about. Traumatic arthritis is going to be reasonably straightforward. This is going to follow a fairly major trauma. Falls downstairs, being kicked in the butt. Fairly major high energy trauma. If the energy is enough, then you can get a fracture of the sacrum and even an intra-articular fracture. And if this is a sacral body fracture, it's going to be associated with probably about half the time with neurological problems as well, and a lot of the times with a fracture of the pubic ramus. So they're going to have pain in the front with neurological signs and symptoms for the most part. Otherwise, you may not be able to figure this is a fracture. What you can do is palpate the body of the sacrum and see if that is giving you pain there. And then there's microtraumatic arthritis, which comes on because the joint is basically unstable, and it can either, using the term advisedly, sprain because of its instability with a minor trigger, not major trauma now, but a minor trigger. It may be a fall onto the butt, but generally simple falls onto bone don't fracture it. So this can be a minor trauma, relatively minor trauma, or they may not be able to relate any trauma at all, but nonetheless you're going to have evidence of a sacroiliitis present. And then the one for us that's going to come up most commonly is a biomechanical dysfunction, which is not going to be inflammatory, so you're not going to have the elements of inflammation present when you're looking at this, and it's going to have the typical illness script or essential illness script of a biomechanical dysfunction. and we'll talk about differentiating that from a lumbar problem later on. The pain locations from SI joint pain, Fortin's area. This is basically the sacral sulcus, and we'll talk a little bit about Fortin's finger test and Fortin's objective testing a little bit later on. But Fortin's area is where basically the sacral sulcus. It's this particular spot though when you're using the test, which is just medial to the ASIS and just inferior to it. Can also occur in the anterior iliac fossa. This is less common, and generally speaking, it's when the ventral ligament of the SI joint has been damaged. Now, the SI joint ligaments are really, really strong. These are amongst the strongest in the body, except for the ventral one, and that one can get damaged with trauma. So you can get ventral pain, but it's unusual. Buttock is very common, particularly for sacroiliitis. And the posterior leg is also common, which can go below the knee if it wants to. The myth about it only going to the knee is garbage. It can go well below the knee. And sometimes if the pain is in the anterior iliac fossa, you can get anterior thigh pain usually. But again, that's less common. And your differential diagnosis there isn't so much with the SI joint as it is with the hip problems. So they're the most common areas, although some of them are uncommon. The most common areas for us to see SI joint pain. The tests that we're going to talk about are specific to the SI joint, or at least reasonably specific to the SI joint. Fortin's finger test is a subjective test. You ask the patient to put a fingertip, not more than a fingertip, on where they feel the pain is either worse or where they feel it's coming from. And it has to be just medial to and slightly inferior to the PSIS. The research on this was done, but didn't have controls. It was all done on SI joint patients. So it looks to be very, very close to being 100% sensitive. It's probably 90% or maybe better. Specificity, we don't know. I find the test actually fairly reliable for identifying SI joint problems. Fortin's objective test basically is one I came up with, and I dare say a lot of other people did as well. But this is palpation of the sacral sulcus on that side. I've only ever seen one SI joint pain that wasn't tender in there, and I really don't understand that, but the rest of them have all been tender in there. Now don't forget, these two, the pain has to be present. This has to be SI joint pain, and of course it has to be posterior, at least for the Fortin's finger test. It's possible that if you've got a ventral ligament problem, the objective palpation Fortin's test may also be positive. I think it's fair to say that if both of these tests are positive, you can be pretty damn sure that the SI joint is producing the pain. The primary stress test is the so-called anterior and posterior gapping, and I would add another one, and this is heel hopping. So you get the patient to you put a stability belt round the pelvis, tighten it up as strong as you can, and you get them to hop down on the heel. So they come down smack on the heel, and they'll either get pain or they won't get pain. But you ask them to appreciate how much pain is going on. Then you take the belt off and you have them do it again and see if there's a major increase in pain. That's also fairly specific as a pain provocation test for the SI joint, because obviously when you come down on your heel, you're jarring all the way through the spine. But what the SI belt is doing is actually holding the SI joint so it can't really move, and therefore has less stress. So I think that takes a lot of the other things out of the equation. Mostly these tests are used for determining the presence of sacroiliac arthritis. You wouldn't use it on a full-blown sacroiliitis from reactive arthritis or anything else, but for microtraumatic arthritis and sometimes traumatic arthritis, these tests can be very useful. The secondary stress tests are about stability, and I only use one for this. This is a posterior shear test. You come in, you palpate the sacrum and the PSIS, you flex and you immediately rotate the leg, so the knee's at around about 90 degrees, and you palpate the space between these, or the position between the sacrum and the PSIS, and then you use your body weight to shear down slowly, shear down on the leg, and you should be able to feel, if that's moving, you should be able to feel differential movement between your two fingers. Not a lot, but you should be able to appreciate there's some movement occurring there. But you've got to take all the slack out of the system when you do it, otherwise all you're doing is rolling them around. So you take all the slack out and then you apply the pressure. And then finally, once you've made the diagnosis of biomechanical dysfunction, will be the biomechanical diagnostic tests. All of the sacroiliitises have similar things in common. Because it's all arthritis, it will be relatively severe pain compared to biomechanical dysfunction, although that can be very painful as well. But sacroiliitises are always more severe. The pain is usually felt in the buttock and tends to be confined there for one reason or another, but it can cause more intense pain the further it can refer out. Fortunate is always positive. There is usually obligate functional loss, although with microtraumatic arthritis there probably won't be that. But with the other types, certainly the systemic ones are all going to look very similar. It's going to be obligate functional loss. All ranges of motion will be positive to some respect or another. So if this is a very severe sacroiliitis, systemic arthritis, then you're going to have a lot of pain in all the movements. They're all going to be limited. With a traumatic arthritis, it may not be as noticeable, and some movements will be a lot more painful than others. And microtraumatic arthritis, you may see that some of these movements are pain-free until you actually push on them. Biomechanical dysfunctions, they're always very specific movements that are painful, and others are not. With systemic arthritis, the chances are there will be other systems affected. If this is a reactive arthritis, then it's likely to be part of Crohn's or Reiter's, so you might see an ulcerative colitis there with gut problems, eye problems, iritis, enthesitis, other joints involved, and so on. Systemic and reactive arthritis both do that. Infective arthritis, you won't see anything else other than that joint, but it will come out of the blue, and there may or may not be temperature raise, as I say. However, with all of these sacroiliitises, if you haven't got an obvious cause for it as a form of traumatic arthritis, it's not really your job to find out why they have it. Your job is to say, well, it's an arthritis, there's no good reason for them to have it, this is probably a medical problem rather than an orthopedic problem, let's get them back to the physician. Traumatic arthritis can look very, very severe, similar to a systemic arthritis, but you've got an immediate onset of trauma. Your biggest problem there is if a fracture's occurred at the same time. These can be intra-articular, it can be in the body of the sacrum itself. As I mentioned, with sacral body fractures, there may well be neurological involvement in this, and another bone, and it's usually part of another fracture somewhere else, pubic ramus. So often you don't see these because of the amount of damage, but sometimes this can be an isolated minor fracture, or it's an insufficiency fracture such as with osteoporosis. All of them though will have a sudden onset of severe pain with a fracture, whereas with a traumatic arthritis without fracture, there may be pain at the time of the injury, but that's going to get worse possibly the next day. And biomechanical dysfunction, as I say, will have the same illness script as any other biomechanical dysfunction. The average will be episodic, moderate pain, although with sacroiliac joint, that moderate pain tends to be a lot worse than it is for other joints, simply because of the size of the joint, I would think, and the number of nociceptors. But that can be really quite severe, especially the atypical ones where it's the first episode, so you haven't got that episodic history, and that first episode can be really very nasty. That's the one that's going to be mistaken for something else. Fortis is definitely going to be positive. And the range of motion will be flexion or extension, rather than both movements. There'll be a non-obligatory loss. And so really, you know, what you're looking at is differentiating out the biomechanical dysfunction from the arthritis. And if you do think it's an arthritis, is there a good enough reason for them to have it? And we'll talk a little bit about how you differentiate between a microtraumatic arthritis and a systemic arthritis, if you like. Now, the other thing you do have to differentiate sacroiliac pain from is the other big area is referred pain, almost entirely from the lumbar spine, although it can be visceral. In both cases, if this is referred from the lumbar spine, first off, 4D's test is going to be negative. They're not going to tell you my pain starts here or this is where it is. They're going to point at the back, or more likely they're going to be running their own hand over the area, but they're not going to be able to put a fingertip on it. Same with visceral pain. This is not going to happen. Also, when you examine the sacroiliac joint with lumbar pain and visceral pain, your local tests will be negative, except where they affect the lumbar spine. So if you're doing PAs on the sacrum, for example, looking for pain provocation, and you're stressing the lumbar sacral joint, and it's the lumbar sacral joint's in trouble, that's going to give you a positive. But you're going to get more of a positive when you do L5 than when you do the sacrum. So you can work out this. So essentially, referred pain gives you negative local signs, even though the symptoms may be in the sacroiliac area, but the signs will be negative. Of course, what you can have is a lumbar problem giving you pain, and combined with a sacroiliac joint problem that's giving you pain, in which case you're going to get a positive and a negative 4D's test. You're going to have to differentiate what pain they're talking about. So if they're talking about the pain in the buttock area, is that positive 4D's, or is it, and they also are positive in the lumbar spine? So where you've got pain arising from both areas, that's a bit more difficult to that, but it's very, very classifiable. Okay, so as I said, basically the primary stress tests are pain provocation tests, whereas the secondary stress tests are tests for instability of the joint. The way you can integrate the two tests is with sacroiliitis, you would expect to see the primary stress test to be positive. 1, 2, or all 3 of them actually. But we're also looking, so we can say we've got sacroiliitis. So now we're looking for what type of sacroiliitis it is. If this is a systemic arthritis, ankylosing spondylitis or reactive arthritis or any of these things, it's unlikely it's going to be unstable. Whereas a microtraumatic arthritis must be unstable to some extent. Whether you can pick that up or not is another matter, but it must be unstable to some extent, and that with practice and with a big enough instability there, you should be able to pick it up with a secondary stress test. So the way it works is this: I diagnose it as a sacroiliitis. I then apply the secondary stress test. If the secondary stress test is positive, that is, the joint is unstable, and you haven't got any of the other characteristics of a systemic arthritis. That's the important thing. You don't have other joints, you don't have enthesitis, iritis, colitis, you haven't got any of that stuff. Just an isolated traumatic arthritis, or isolated arthritis. If all of that's absent and we have a positive secondary stress test, it's reasonable to argue that this is a microtraumatic arthritis. On the other hand, if the secondary stress tests are negative, then you really want to be worried about it being systemic, and it may be the first episode of this rule. You know, the fact that they don't have anything else doesn't mean to say it isn't a systemic arthritis. So those ones I would send back to the physician. The ones that are secondary instabilities or instability present, then I would treat it. Now I've got an example of where this goes wrong, actually where it doesn't go wrong, but I went wrong. This was a neighbour complaining of severe buttock pain, and she's 50 odd, or she was, and this came off no good reason. She could tell she'd never had it before, and it was really bad. She couldn't sleep in the bed, she had to sleep with a mattress on the floor, sleep on the mattress. Same stuff, turned over and it caught with a sharp stinging pain. There was no other systems involved, just this, but everything was screaming this is an inflamed sacroiliac joint. Now, what I should have done was done a secondary stress test, because I would have probably found they were positive. What I did do, because she was a neighbour and a friend, and she wasn't a patient, which is the big thing here, is I didn't do the secondary stability test, so I fired her off to her physician. This was just not in the clinic, this is in my house. And I fired her off to her physician, but she never went there. She went to a chiropractor and manipulated her back, and it got better. So this was entirely my mistake. I should have done a secondary stress test with her, and then I would have probably manipulated the back myself. But you're better off making an error on the safe side than the risky side. Personally, I think the chiropractor got very lucky, because I know he didn't do a secondary stress test, because they never do. but that was entirely my fault. So I think this works. This slide is basically breaking down sacroiliac joint lesions into major, minor and referred. The major ones are, we've already really talked about, and this is traumatically looking at basically fractures, healthy bone fractures, anterior joint ligament tearing. So this is going to give you some onset of severe pain. Then you've got insufficiency fractures, which is generally pathological fractures, osteoporosis, which will give you sudden onset of the severest pain as well, but the pain is not going to be anywhere near as severe. And if this is a stress fracture, this can come on very gradually. So you're going to see a much less severe problem than you will do with a healthy bone fracture. The chances are that you're not going to see a healthy bone fracture. There's too much else going on there, neurological complications and so on. But the stress fracture you might do, the combination of osteoporosis and abnormal stresses, that can come on much more gradually. Atraumatic fractures, you can have tumours in there, and of course septic arthritis, as we said, systemic and reactive sacroiliitis. On the minor side, traumatic arthritis and atraumatic stress fractures, degenerate ligament tears, tendinoses, biomechanical dysfunctions all around this joint. So this is sacroiliac area pain. And then finally, referred pain. Lumbar spine is a big one, of course, and viscera. So the local tests will be negative, with the exception, as I say, where your tests affect the lumbar spine. But you're not going to really be able to reproduce that pain when you can isolate the test to the SIJ, which you can't always. So Fodden's test is a big thing here for looking at referred pain. So make use of it. Really, your main problem here is differentiating out the biomechanical dysfunction from the sacroiliitises. And then when you've found a sacroiliitis, differentiating between the more benign sacroiliitises and the ones that you have to get out of your clinic. Not a real big problem. Most of the stuff you're going to see will be biomechanical dysfunctions. Later on, when you start getting more complex, you'll be looking at the problem then comes when the sacroiliac joint isn't painful, but it is stressing out the lumbar spine, and it still needs to be treated even though it isn't painful. That's another step up in clinical reasoning. All right, guys, so I hope this helps. You take care. Oh, on this slide, by the way, I'll give you a PDF so you can look at this in your own time.